Okay, good afternoon. Well, I want to say Kentucky welcomes a new state to the concept of Public Health 3.0. You've already been doing it, you just don't know you've been doing it. So, who's a chief health strategist in this room? Everybody should raise your hand because you all are. Even if you don't consider yourself such, you will probably by the end of this forum. So, here's Kentucky. Buffalo Trace, some of the finest bourbon in the country. All the bourbon in the country comes from Kentucky, but some of the finest comes from Buffalo Trace, the distillery. So, we have lots of great stuff in Kentucky, lots of great stuff. Kentucky Derby, day after tomorrow, the most exciting 2 minutes in sports. But we in Kentucky, we party for 2 weeks leading up to it. So a lot goes on during that. But we can use that as a preparedness exercise. We do our big events in Kentucky like that. So public health rallies around, and we structure it such that we are doing an exercise related to, what would happen if something went wrong. So we feel like we've got a decent handle on that. Also, Kentucky basketball, we love it, whether we're doing any good or not. But we're usually way up on top. And Kentucky cheerleading, that's not familiar to a lot of places outside southeastern part of the United States. But Kentucky holds 23 national titles, and the cheerleaders are really athletes. So we're very proud of this stuff, and we would settle for no less than being first in these things. But look at this mess. So we So we are settling for way than best here. And we struggle with these things every day. And of late, we're leading in overdose deaths, Hep C, and that is like Dr. Thomas said, the epidemic of our time. We are really struggling with that. But this challenge that we have brought us together in some ways, and I'm going to talk about that because I think here in Illinois you've had some challenges, and they may be financial in nature or health related or both, but I think you can hear some of the things that we're going to talk about, and they may resonate with you. So on our journey for Public Health 3.0 and Chief Health Strategist, these are just a few of the things that we're going to be talking about today. But it's a list of things to let you know that there is no one place to start. There's no one place to start. You start everywhere with everything. So 2 years of legislative meet and greets. We started out with, we need to tell our legislators, and who better than the people at the local level, the health departments, let our legislators, the people that sign our paycheck more or less, or the money that we get, we have to let them know we do not want to settle for the health status that we have in Kentucky. And maybe just draw their attention to it if they're not paying attention. If they're only looking at Kentucky basketball, we need them to look at some of the other things going on, and that we need to be funded such that we can do something about it. So we started, and you can see, I think this one was 2014, but we've taken a show on the road. We go meet legislators where they are, which is capital city of Frankfort, this capital city of Illinois here. Frankfort is capital of Kentucky. But we also hit them when they were outside legislative session. We would go to their jurisdictions and have, tempt them in with some food and then talk to them. But we've been doing that for a while now, so they are starting to. Some of us, they like us. Some of them. Some of them would prefer us to leave them alone. But we have done lots of presentations for them. So the ones that do like us, they ask us to come. So here's Kentucky Medical Association. There's our governor. He's an interesting character. And then we have what's called county judge executives, and they're not legal judges. They are like the CEO of the county. We have 120 counties in Kentucky. We have 102 here, right? So these guys make lots of rules. They control the money at the county level, so we want them to understand what it is we do at the health department. And then there you can see Allison, our leader, leading the charge with lots of meetings. We've been all over Kentucky. Any place there's a group like this together, we're going to talk to them. And as you can see, we'll come outside of Kentucky too, because we're very, very passionate about this Public Health 3.0. So I'm going to show you how we got started. I hope this works. So this group, we were the antelope here. This is us, the antelope. The lions at the bottom of the tree, that was what we perceived to be our Kentucky State Department of Public Health. So we thought they were going to eat us, but what really happened was we just laid down and let them. So we decided that we must come together. We must hand them a plan, our state, not just our State Department of Public Health, but our legislators, about how public health should be done in Kentucky. And we got to the point, you saw where we ranked on all the bad statistics. We can only go up from here, you know, so I don't want you all to get to that point, but when change has to happen, sometimes it happens through pain, and that's what happened to us. But it did bring us together. We were at one of Kentucky's beautiful state parks right there, and we spent several days together, and we worked on our first successful strategic plan. Okay, so here's what we thought. What do we need to do to make Kentucky a better place? We've got a lot of resources. We're just putting them in a lot of the wrong places. We've got to direct them in places where they will make a difference, make a change. We do not need to keep doing the same old programs, the stinky cheese. We shouldn't keep doing that if it's not working. Let's do some things that will work. And then also, we have to have partners. We can't do it alone. We know we don't have the money. We don't have the manpower. We have half the number of health department employees in Kentucky that we used to have, and we're expected to do more. We've got more work to do. It's exciting work, thank goodness. Also, Public Health 3.0, we were looking at these concepts before it had a name. You are looking at these concepts before it has a name. And I think the name is not what's important, although that makes it easy for people to refer to, but it's the concepts of public health, and especially the political aspect of this. We want to stay out of that. At least I do. I would never ever be successful in politics because I can't maneuver far right, far left, all that stuff. And I really don't want something as wonderful as Public Health 3.0 to get thrown out the door just because of its title, because the concepts are solid and we have been doing them since the beginning of public health. And also, we decided this would kind of be our mantra. So, to be brave, you have to not conform. So if it is not working, break out of that. Somebody said be fearless. Maybe a couple times you've said that. You can be afraid. We've done several things when we were terrified, but you do it anyway. You do it anyway. If you know it's the right thing and we have to do something different, you've got to break out of conformity. So here's our very first, not our first attempt at a strategic plan, but our first successful strategic plan. You have a copy of that book on your table. So feel free, if that will help you in any way, to take it. If not, leave it. We'll pack it up and take it with us somewhere else. But we worked on this. We formed work groups. We took our show on the road. We printed this nifty book. But one of the most interesting concepts, and you have this, and we're still working on it, so we'll get to 2019 strategic plan that still has this in it. This is a funding model that we have proposed. Now, what's on your table could possibly be a rendition from the beginning. It's had several revisions. But what we looked at, based on the foundational capabilities, and Dr. Thomas said I would mention that, but we looked at the different categories of what public health should be doing at its core. And then we determined, how do we make that happen? How many people does it take to make that happen? And we came up with our little bitty health departments. On there you can see Kentucky has little bitty health departments. We have more little bitty health departments than any other kind. So how do we get this done? Preparedness, epidemiology, how do we get these things done with such a small amount of people doing it? So we calculated, we came together, every size health department formed a work group and looked at the number of hours that we spent doing just these services. And not services outside of that. We do a whole bunch of other stuff besides this. We do a lot of clinical services. We do a lot of programs. that are great programs, but they're not these foundational capabilities. And in Kentucky, these are actually in statute. We don't get any money to do them, but it's in statute. Thou shalt do this at the health department. So we wanted to figure out how many people it would take. So you've got several renditions there, but we finally arrived at, for every 12,500 people in population, you need 2.5 FTEs. Now that doesn't mean 2.5 people. You probably need more than 2.5 people, but 2.5 FTEs, because you may have a preparedness planner that's also an environmentalist, or a nurse that's also an epidemiologist. You may not be able to, get all that wrapped up in one person. But this is where we arrived, and from that number, we looked at our average cost for the employee. We started out with just their salary, but then we threw in administrative costs and other things that we have to take care of. And we arrived at a figure of $116 million that we could do these. That's, to me, that's a giant amount of money, but to, our state government, that's nothing. But we can get this work done. Now, this is not taking in consideration things like WIC and HANDS, that's a home visiting things that have their own funding source. These are those foundational capabilities that we do not get money specifically to do, just these things. So we came up with this model, and we are continuing to move forward with revising it, and we have taken it to a lot of people. I put it in the hand of Dr. Thomas's boss a week or two ago, and he came to Louisville. But we really think that this is the future of where we need to go in Kentucky. We're spending twice that amount of money, over twice that amount of money right now, to be 50th in the country in health status. So we need to do something different. So meanwhile, guess what happens? Look at this, Karen DeSalvo. So Allison and I have made several treks to visit her as she was going along. And actually, Allison and some other health department directors were involved when she was going across the country looking at the things that were working on the local level. This is the concepts on which Public Health 3.0 was built. So we were involved in that, and it was fitting right in with our strategic plan. And actually, there she is. That's George's Benjamin next to her there at the launching at DC, the national launching of Public Health 3.0. So we were there. We were cheering her on. Yay, we like that. This is working for us. So we want to get our boards of health. Remember, we want to tell our story to everybody. Our boards of health in Kentucky are very powerful. Sometimes, like the attorney said, they don't know they are. Sometimes they don't know how powerful they are. But we wanted them to understand what's going on. So we had a live broadcast state board of health meetings that went out across the entire state, and this was a part of it.
Thank you, Georgia, and thank you all for inviting me to address this first ever statewide local boards of health meeting. Your work comes at an important moment for both public health and for our country. Today, we can look at the past few years and see an unmatched legacy of progress, including 20 million more Americans who now have access to the health insurance they need for themselves and their families. But when we look around, we also see challenges, including growing gaps and disparities in neighborhoods throughout our country. The latest research shows that if we are going to eliminate those disparities and lift up our neighbors, we need to build strong communities. We need a systems-level approach to public health, one that focuses on the social determinants, because we know that health is more than health care. We need to focus on making the healthy choice the easy choice, where we live, learn, work, and play every day. And that is why we started our new initiative, Public Health 3.0. Our goal is to change the conversation in this country and get every sector involved in improving health and well-being. As I have traveled across this country, I have visited many communities at different stages of working together to improve health. The local public health professionals in Kentucky are leaders among them. The work in costing out the foundational public health services and capabilities by KHDA is a great example of this. I know that together we can create a culture of public health here and throughout our country. And Georgia and Allison will talk about how we can do that through Public Health 3.0. But for now, I wish you a happy new year and success on your journey to a healthier Kentucky. I thank you personally for your inspiring and impactful work.
Okay, so Allison has been our leader, Kada, that she referred to as our SACHO, and she's been our president for the last couple of years. I feel strongly that she'll be serving another term. She disagrees a little bit, but she is rallying the troops, continuing to do that, and she's going to tell you about that.
Thank you, Georgia, and I want to thank you all for inviting me here, and I'm excited to be able to share information to another state. I think the more states we get on board, you know, when you think about grassroots, not only at our local level, but at state level, if we come together, maybe we'll have a little bit more impact at the federal level, and we can start making the changes from the bottoms up and moving forward, and not have to worry about you know, what's coming in every 4 years. So, like Georgia said, our goal is to really start rallying the troops and talking about it to everyone, from our local leaders to our state legislators to our boards of health. And we enacted a plan that rallied our health department organization together, that we have 100% of our health department directors who are a member of our SACHO, which we call CADA. So I'll refer to CADA from now on. And we made it our legislative agenda. When it started moving forward, we decided that it was not a budget year, not an issue year, if you will. So we were going to spend that year just meeting and greeting policymakers, our legislators, our executive branch, and begin to educate them about Public Health 3.0. And so you have one of these on your table as well. This was, I tout this because although we are last in a lot of things, we are being first in trying to enact local change. And this document was our legislative agenda a year and a half before Public Health 3.0 became popular and was launched. And if you just look at our tomorrow, what we were asking our legislators for is to develop and implement a funding structure for local health departments designed to improve Kentucky's health status. So we were looking at changing or transforming or moving into a 21st century infrastructure long before Public Health 3.0 became popular. But once it was launched, we wanted to tag on to the national platform, and we were able to secure all of what we would call our K public health groups to adopt it as their 2017 legislative platform. So our Kentucky Public Health Association, our association, we have a local Board of Health Association, and the Public Health Institute, all of us collectively adopted the legislative platform and made sure that we were going around talking nothing but Public Health 3.0 and what it could do for Kentucky. And so we launched it, and we moved forward to assuring that our local health departments were ready to become chief health strategists or transition to chief health strategists. And so we held a retreat, and we had a big placard, and we all took this pledge. And I'm really proud of this pledge. We got 100% of our leadership to adopt this as their mantra, to come together. You know, sometimes we even operate in individual silos amongst ourselves, and we felt that unification was the key in enacting change from the local level. So if we were all singing from the same songbook, if you will, and we were taking this pledge together, it solidified our dedication to Public Health 3.0. And so this is everyone's. Oh, I'm sorry, I can read it. I pledge to be a strategic leader in my jurisdiction to create lasting improvements for the health of everyone in Kentucky. I will advocate for laws that promote and protect the health of all Kentuckians. I will promote health in all policies at all levels. I will collaborate across all sectors for quality life improvement within my jurisdiction. I will be an activist for funding that supports core infrastructure for local health departments, as well as for community level work to address the social determinants of health. And so we all signed it. 100% of us took this pledge right here in our fall retreat that we come together. This was a year after the picture that Georgia showed you of all of us coming together. And so from there, what do you need? What do you need from your organization and from your partners to help us get started? And so they wanted training, of course. So Georgia and I took it upon ourselves to go across the state of Kentucky in regional levels. And I feel like did I just get turned up? Okay, good. All right, great. I was like, what just happened? Woo. So anyway, this is an agenda. We did 6 regional meetings across the state of Kentucky, brought our local public health leaders. So we challenged the health department director to come, which they did, all of them, and then bring any key leadership they wanted, because like you've been told, you may not be the only chief health strategist or the only strategist. You might have strategists within your organization coming together. So it's important to really empower just the strategic thinking. Out of the box is kind of an old cliche, but it truly is a different way of thinking and expecting better health outcomes for your organization. So just briefly, we did have a little bit of sponsor funding for us to do this out of our Foundation for a Healthy Kentucky. And what we explained, what's 3.0, and I'll tell you a little bit about that. I'll show you some slides. But the most important thing that we talked about is local advocacy and training. How do you have difficult conversations or talking to your leaders, or government, local, state legislators, community leaders, business partners, hospital CEOs? How do you start talking health and getting them to understand that they have a huge role to play in the health improvement of the jurisdictions they serve? So our goal is really to create this 21st century public health infrastructure at the local level and ultimately present it as a plan to consider at our legislative level, because we do understand that change happen at executive levels, and so having it legislatively, and we're a part of that, make sure that the continuity stays over time, over executive leadership. So that's our ultimate goal as an organization, moving Kentucky. We're close to getting what I would call some key buy-in. We're not there yet, so I don't want to mislead you, but we'll tell you a little bit of the next steps that we're working on. This is a picture. Georgia did this presentation, and she's put my picture in it. You will know that she's not in any of these, so I have to get her on it. This is me leading one of the Chief Health Strategist trainings on a regional level. So the concepts of 3.0 you're going to hear for the next 2 days. So I don't want to spend a lot of time on what the concepts are, because they're out there. The white paper is there. What I want to talk to you about is these concepts, how we made it for Kentucky, how you make it applicable to what it is for Illinois. Find out what you're doing already that matches up into these concepts to springboard you, especially to inspire that, hey, we're really already doing some of these things. And then the other thing that we did for Kentucky is dream big. What is it that we could do in Kentucky that would measure in, that would work into this concept that we don't have, but would be really nice as we're moving forward. So the first concept is public health leaders should embrace that role. So we wanted to make sure that our chief health strategists began to step out of the box of clinic services and siloed funding and making sure we did this service in order to get the funding, to start thinking bigger. What would those population health improvements for their community be? Start identifying strategies around the social determinants. We needed to modernize our local public health employment merit system, which is a whole nother story, and we're going to be here plenty of time for you to talk to us about that. We wanted to advocate for autonomy within each of our local health departments, so we can really be astute to our community health assessments and start identifying how we can address those. And then we wanted to empower all of our boards of health to advocate for the health in all policies. So you've already seen the high five, the different strategies, and these are the 3 documents that we were educating from. You might have seen this. This is from the county health rankings, and we're looking at, we want to improve our health factors in our community. That's what population health is, not what's happening today. We're looking at what we can do to improve our health factors for tomorrow's health. And it's probably not any news to you all in this room, but definitely to key leadership and government leadership, as you know. Educating them on that clinical care or access to health care is only 20% impactful in the overall health of a person. And this is, our model. We look at what has the biggest impact on health. And as you can see, health behaviors 30% and the social and economic factors 40%. Those are where we should be focusing our energies on in bringing groups together. So this is just a talking point on the training that we were providing for our chief health strategist. And then this comes from the CDC. Again, we're mostly still doing lots of top pyramid stuff in Kentucky, and it does take a bigger thought process to start looking at what can we do at the bottom. And one of the challenges is when you start talking about, hey, we need to do less clinical interventions, the cheese has been moved, and it starts to scare everybody. Then it's like, well, there's no need for health departments anymore, and and it's like, oh, time out. Yes, there's a huge need for health departments. We just need to figure out how we either change our skill sets, train our staff to start working on the bottom line parts of our pyramid. So I do want to make sure that we're clear that there can be, if you're not talking the right message or giving the right message, if you say, well, we don't need to do counseling, education, and clinical interventions, that's not doing anything for the improvement of the health. It's not because we shouldn't be doing those at all. We should just not do them in forego of the things at the bottom of the pyramid that we know we have bigger impact. And lots of flexibility of what's going on. What is the need in your community, but making sure that you're giving your due attention to those bottom of the pyramid, the things that have the largest impact. And I talk a lot about, people don't know what's happening at the bottom of the pyramid, and so therefore we often are the best kept secret. What are we doing? We can't see anything. If someone can't come in our door to receive a service, then what is the health department doing? So we have to be out there in the community, and these are the things that we're telling our Kentucky leaders. And then you've heard focus on population health and the social determinants. And I like the wheel. I think it puts it all in perspective. In order to have the healthy human being, we need to make sure that we're addressing all of these. And that egg chart moving together, we can't do all of this. We have to bring our community partners together. So on to the second concept, forming vibrant structures and cross-sector partnerships. So we were looking at applying some sort of accountability measure. So Kentucky doesn't have a state mandate to become accredited. So there's not that already built in like Illinois has to have that accountability measure for a local health assessment. So we're looking at how can we build in an accountability measure for a health assessment, and then require local community health improvement plans that identifies those local partners. So how can we just make it pertinent for Kentucky to assure that these are happening at the community level? And then, of course, bringing in the boards of health. I think on this jelly bean chart or a skill chart or egg chart, whichever you want to call it, I really like this rendition because we often leave out the powers of the Board of Health and how instrumental they are working together with the Public Health Department and the Chief Health Strategist. How can they be the biggest cheerleaders or the ones out in front that are often simultaneous or partners with local government leaders, or often is the local government leader. Supporting local public health department accreditation. So this is something that is a work in progress that Georgia has been working very hard at, is trying to find out how we can have an accountability piece in local health departments that gives sort of like what's the minimum public health accreditation like requirements for all of our state and local health departments, and establish an accountability performance measure for local health departments, and ultimately identify the statewide strategies to improve health. And so we're excited in Kentucky. I think it's amazing that we are not required to have accreditation, but yet there are 15 FAB accredited health departments, which is, we're one of the top states leading the nation, and we're not mandated to do it. So I think that says a lot about Kentucky local leadership. We want to do better. We want to improve our health outcomes, and we feel like having accredited health departments are moving us in that direction. And more every year, we're working on getting our accredited status. Actionable data. This is very difficult in Kentucky, especially around, where local health departments aren't electronic. We don't have EHRs or public health records. So we have advocated for strategy. We have managed Medicaid in Kentucky. I don't know about Illinois. And so we're looking at pushing some policies around required data sharing as it relates to the managed Medicaid contract. So it'll be an easy data sharing, HIPAA, already compliant, to where it's an agreement or required sharing of data. So we're hoping to move forward on that. And then, of course, we're trying to advocate for a public health record in Kentucky that's got data that can be extrapolated. And we have a Kentucky Health Information Exchange, but we're not able to mesh and grab data according to zip codes, street addresses, things like that, illnesses, that kind of thing. We're looking at that. This is what we do have. This is what we're using, and I think we have 2-year-old data. Sometimes we're really excited to get 2-year-old data. Most times it's 5 or 6 years old. But what I really want to point out here is in Kentucky there are health departments that have funding or have grants that are allowing them to create their own database. And this one here in the corner is from Ashland-Boyd County, and it's their syringe exchange program, their substance abuse prevention, that they're able to put real-time data, and they're keeping the community informed of the number of syringes they're bringing in, taking out, and it's real-time data that the community is seeing the health department as a place that's collecting data and delivering. So number 5 is really what we think is the baseline in Kentucky, and we have stole this tree rendition from David Fleming over and over and over again, and this has been what we've been putting in front of our legislators when it comes to understanding how our public health system is funded currently in Kentucky. And perhaps nationally, according to David Fleming. But all of our funding, the trees, have y'all seen this? Have you seen this before? Okay, great. So it's new. It's exciting. The dead tree right here, all the funding are in the leaves, so we're only taking care of the leaves. So a leaf is a program that we all are familiar with. We get a certain amount of money for a program. We get all excited. We are gung-ho to it. 2 years later, funding's gone, right? You've been there, right? Or you put all your energy in it, and it might cost more money to deliver the program than you actually have. And so it's not sustainable. It's eventually going to die. So what we're advocating for in changing the funding so that we're working on foundational funding. We're not funding the leaves, we're funding the tree trunk and the branches so that we're able to be flexible, if you will, or responsive to our community health assessment or what's going on in our community. So instead of saying you have this program, this money, deliver it in your jurisdiction. We don't care if you really need it or not. Just do it because that's where the money is. That's how our tree. And then what happens? The things that really need to be happening in our community, we don't have money to do. So when you hear about foundational funding, whether you see it from John Arbach's view that you were presented earlier, or you see it in the form of a pictograph of a tree, it's basically how do we fund the tree so that it stays vibrant and continues to blossom and grow year after year after year, and we're not worried about the funding going away, that we won't be able to be responsive. And so the things that are the foundational capabilities, if we're funded this way, we're able to immediately redirect the funding where it needs, whether it's an emergency response or whether it's addressing a social determinant, pulling partners together, we're able to do that with this type of funding mechanism. So in Kentucky, this is what we're looking for, modifying our funding structure, similar, the model based on what Georgia just presented earlier. We're looking for those opportunities to enhance our funding, whether it's statute, whether it's understanding of bringing some funding away from another pot of money into a more flexible looking structure, and then allowing expenditures for local public health foundational capabilities and statutory requirements instead of programmatic. And it's a shift. We are definitely moving cheese around, getting people to understand that there's a different need to go away from program funding to a more foundational funding. For example, and I tout this in Kentucky because it really is about Kentucky, and I have no idea how Illinois is, but for some programs in Kentucky, federal money, it cost us 4 times more to deliver the program based on the requirements than we actually get. And so the leaf is dying very quickly, and we're not being able to do anything else with that funding. So, I mean, it's my mission, our mission, Kentucky's mission is to just make people aware of that. Even if it's a great program and it was wonderful, the cheese is beginning to stink for sure when it finds out that it's costing more to deliver and we're not able to utilize those resources elsewhere. The other thing that the principle of this is, what is population? When you think about population, is it the big picture, everybody in your jurisdiction, or is it 1 or 2 people in a certain area? Which is it? So when you think about how much money you might be spending on a particular program, who is it affecting? 1 person or 10 people? Or think about that funding. Is it, the model, should we be spending $10 on 1 person or $1 on 10 people? That's the model. Like, what that service you do, does it affect more than 1 person, or is it just that 1 person? And evaluate your program on, if your public health, your population health, where and how that money is being spent, and what's the impact. Of course, you can see in Kentucky, Georgia said we spend $300 million in public health, and we're getting 50th in health status. So clear, and we have 15 accredited health departments. So clearly, there's some misunderstanding or movement of money or program that we could be doing differently. So here we are. What does it cost? So we were going to legislators, and they're like, you know what, Allison, that sounds really great, and I'm getting your concept, and it's starting to make a little bit of sense. But how much does it really cost to do that? To do those things that we statutorily require you to do? And I was like, Mr. Legislator, that's a good question, because there's so many things that come into account. What would it take? And that's really how this developed, and it's just spiraled and grown on how to determine how much does it actually cost to do services or to do foundational services. And this is just a particular model of just the foundation things, and like Georgia explained, based on the population you serve, how many FTEs to do these things. So we moved on into the legislator, and we were able to get on some legislative agendas. We were able to get in front of health and welfare a couple of times. We had sessions inside the walls of the Capitol, and we inspired, if you will, or empowered our local health departments to become chief health strategists in the legislative sessions.
Okay, so there's a lot more could be said about that model. We can go on and on about it because we also have proposals of where that money should come from. We have local taxing districts in Kentucky that produce way more than this money, but they're spending it a different way. Also, we pay giant amounts of money to the managed Medicaid companies. Just a tiny speck of what they spend could fund everything we do. So we're pitching that out there. That's you have to be a little bit fearless to do that because there's some pushback. We participated in a study, though, that helped us a lot. Glenn Mays, a lot of you are probably familiar with him. He's at the College of Public Health in Kentucky, which their motto, by the way, is health for all y'all. So I just love that. But anyway, so he did some study with some really high-level statistical models on this funding and how to pay for foundational capabilities. And our thing that we did with a work group of health department directors in Kentucky lined up really well with the work that he did. Also, he's been part of a 20-year plus study about comprehensive public health systems, which means if the whole community is working together to make you healthy, life expectancy in that area is higher, and that's shown over and over and over the past 20 years. So we dangle that in front of our legislators too, to say, look, if you fund this instead of one or two services over here, if you fund us foundationally, we'll all live longer. It'll be health for all y'all. We also applied for grants, and some money we have gotten. We've been successful in some places, other places not. So I'm going to make fun of FAB for a second. Although I love them, they took a public health superstar that you all from Kentucky that you all will hear from later during your forum and snatched her up. Now she works for them. They also did not fund us for this grant that we applied for, but I still love them. I'm still a huge cheerleader for accreditation. So back to, we're still talking to anybody that will listen, including you all. So these are some other people that we go asking money, go for them. And this past year, I want to say Outstanding Public Health Director of the Year here. So she's done some great work and worked really hard.
I've got just one quick wrap up. I want to tell you where we're going for 2019, and also let you know that we're willing to share anything. And then we just hope that you'll share back. If you whatever you built upon our work, we want to make sure it keeps flowing. Especially we share borders, so there's a great opportunity. So the Kentucky Health Department, Arcata, we're moving forward for another strategic plan, and what has grown out of this is strategic work groups to move us into transforming 21st century public health infrastructure in Kentucky. And I believe our local health department colleagues have, for the most part, the majority of us have embraced becoming not only the chief health strategist in our community, but coming together as an organization, and our organization becoming the chief health strategist for the state. And I'm super excited about that. So those work groups are looking at staffing. Right now we are in a governmental merit system that's costing us a lot of money at the local level to deliver. And what would it look like if we were able to create some sort of a better staffing model? So we've got work groups looking for that. We've got programmatic best practices, which is sometimes a very scary thing to embark upon, because we're looking at, yes, we understand the state telling us exactly how you have to do it, but we're the ones doing it. Can we bring them back up and say, do we need this step? Do we need this process? So they're looking at a lot of the programs that have either state or federal money tied to it, and how can we do the bare minimum with the best outcome and make sure the money matches the program. We're looking at the workforce reduction plan, and that sounds scary in a workforce development conference, but the reduction plan basically gives us an outline of making sure that we protect the workforce that is able to meet the Public Health 3.0 concepts. So when you're in Kentucky, when we're working in a merit system, sometimes old school thinking is seniority rules, or that sort of thing. And seniority in our case may not necessarily be the staffing people, the qualifications that we need should we have to enact a workforce reduction plan. So we want to make sure that our plan matches up to make sure that we protect the knowledge, skills, and abilities that we need moving forward in a 21st century infrastructure. So we got a group working on that. And then we have what we call a memorandum of agreement. Maybe you all have something similar to that, but when the state gets federal funding that comes to them, that comes down to us, we sign and says this is what we'll do for it. And right now it's a kind of an all or nothing deal for Kentucky. So we're looking at doing a little bit more of a negotiation on that agreement to allow for more flexibility, so that the chief health strategists in communities that may be a little bit ahead of the game within our Kentucky counties, who have already reached out and had collaborative partners and are assuring services, that they don't have to do that particular program because they've got it assured oftentimes with no money attached. And so right now that we don't have a structure that allows that, it's kind of still do it anyway, which is clearly inefficient and definitely not effective. So we have a group working on that. And just lastly, what we're doing is, as we're coming together as an organization to be a chief health strategist, is we are growing more and more fearless as the days go on. It's been a scary time, but the more people are out there with you. And so the challenge for you all as you're moving forward in Public Health 3.0, developing your workforce, is truly to be fearless chief health strategists and not conceding to this is how it's always been. And that's why we do it. Because in Kentucky, it's getting us 50th in the nation. You all are, a little bit better than us. You're 27th, 28th, depending on, so that's good. Good way to go, Illinois. You're better than us. But still, we all have room for improvement, and the gap is getting wider as we sit here in this room. So working on addressing those social determinants really will have a positive impact as we come together to improve the health of our nation when we're talking about state to state.
So I love quotes, and I want to leave you with a couple. This is us, everybody in the room. We have to not let the fear, you may have it, you may be feeling it. I do a lot of times, but you have to go on. So poorly developed sense of fear, that's what we need, and no concept of the odds. So don't let anybody tell you it can't be done. It can be done. And this is our mission, that we redefine what we accept as quality of life, health for our citizens. So that's where we are. So I may have stressed Lisa a little, but so I think that's all we have, and we'd be happy to sit down or take questions, either one.